My name is Dr. Nicole Hamp. I am a Developmental Behavioral Pediatrics Fellow at the University of Michigan after having recently completed my residency training at the University of Chicago. Over 3 years, from the summer of 2016 to the summer of 2019, I worked closely with Amy Zimmerman and the Legal Council for Health Justice to achieve automatic eligibility to early intervention services for children who have been lead exposed in the state of Illinois. The legislation we worked on was recently passed and will require the Illinois Early Intervention Program to have rules in place by July 2020, establishing automatic eligibility for children birth to age 3 years with confirmed elevated blood lead levels at 5 micrograms per deciliter or greater as a medical condition resulting in a high probability of developmental delay. This means children will be able to receive proactive EI services whether or not they are currently demonstrating any delay in order to enhance early learning and help prevent any future delays. This talk was developed for pediatric healthcare providers with the purpose of enhancing education around the neurocognitive effects of low-level lead poisoning so that providers can better understand and explain to families the implications of low-level lead poisoning and the potential benefits of early intervention. Our objectives for the talk are to understand the basics of exposure, how and why it occurs and why children are more susceptible, identify the symptoms of lead poisoning, explain some of the pathophysiology behind lead poisoning, specifically how it affects development, and appreciate the role of pediatric healthcare providers in early identification and appropriate referral and follow-up. Lead exposure can happen anywhere. It wasn't until the 1970s that lead was removed from new paint, even though the risk had been known for at least a half-century. Leaded gasoline from cars was not completely phased out until the 1990s, and lead pipes and plumbing were permitted for use in construction as recently as 1986. So lead remains ubiquitous in our environment, in dust from paint, in soil and dirt, in the water, and in consumer products, both foreign and domestic. Still, the most common source of lead poisoning is from lead paint, specifically lead paint dust that people can either ingest or inhale. This is an important topic for pediatric healthcare providers to understand and feel comfortable with, because while it is true that all people are at risk of lead exposure and lead toxicity, children are at increased risk when compared to adults. This is for several reasons. First, they have increased exposure. From a behavioral perspective, they have increased exposure because when children are young, they are on the ground. They are crawling, exploring their environment, and practicing hand-to-mouth behavior. And from a physiological perspective, they have increased exposure because they have higher baseline respiratory rates, so they inhale more lead dust than adults do. Second, they have an immature blood-brain barrier, allowing lead in the blood to more easily enter the brain and impact the developing nervous system. Third, after ingesting lead, children absorb more lead from the GI tract than adults. They can absorb up to 70% of lead that has been ingested, whereas adults only absorb about 20%. And finally, once absorbed, children retain more lead than adults. Children younger than 2 years of age retain approximately 1/2 of absorbed lead, whereas adults retain ultimately only about 1%. For children, even a one-time exposure can cause harm. Those at highest risk for lead exposure include children less than 6 years of age, particularly those between 12 and 36 months, those with persistent oral behaviors, those with poor hygiene or poor nutrition, also children living in urban, low-income households, children from minority families, and of course, those residing in deteriorating pre-1970s housing. It is important to remember that lead poisoning is really a health disparities issue. The graph on the bottom of the slide highlights data from the 2016 Illinois surveillance report, which found that 3.2% of Black children, compared with 1.6% of white children, had a blood lead level at or above 5 micrograms per deciliter, meaning that a Black child was 50% more likely to have a blood lead level of 5 and above. Additionally, 0.8% of Black children compared to 0.5% of white children tested had a blood lead level of 10 and above, meaning a Black child was 38% more likely to have a blood lead level at 10 and above. Compared to the 2015 data seen in the blue chart above, the prevalence of confirmed elevated lead levels in Black children and white children have gone down, which is good news. However, the prevalence has gone up slightly in Hispanic and Latin children, and these disparities remain. Lead is not metabolized. It is directly absorbed, distributed, and excreted. When lead is inhaled, some is cleared by our body's innate defense system, but up to 30 to 50% of inhaled lead dust is absorbed into the bloodstream. Similarly, when lead is ingested, some is cleared from the GI system. Absorption rates differ depending on age and nutritional status. However, on average, people ultimately absorb between 5 and 50% of the lead that is ingested. Once absorbed from the GI or respiratory tract, lead is distributed between the blood, soft tissues, and mineralized tissues. In children, more than 70% of the total body burden of lead is contained in the mineralized tissues. The rest is distributed between blood and soft tissues. Thus, blood lead levels are not very accurate reflections of the total lead in the body. The half-life of lead in these various compartments depends on the specific compartment and the age of the person. However, on average, lead stays in the blood from 28 to 36 days, in soft tissues for about 40 days, and in the bones for over 25 years. Once in the bones, lead lands in one of two compartments: a labile compartment that readily exchanges lead with the blood, and an inert compartment that is mobilized during periods of stress on the body, for example, during pregnancy, lactation, fractures, or in times of disease. Therefore, lead in bones can allow for blood lead levels to remain elevated long after the initial exposure has occurred. And because the body accumulates lead over a lifetime and releases it slowly, an individual may have high blood lead levels even without an additional major lead exposure. Absorbed lead is excreted by the kidneys, and adults are able to excrete more lead than children are. So how much lead is safe? Over time, the understanding of how much lead is safe has changed. We have long known that lead is toxic to the body at high levels because at these levels there are outward symptoms of lead poisoning. However, since the 1970s, a growing body of research demonstrates that lead causes irreversible, asymptomatic effects far below levels previously considered safe. Today we know that there is truly no safe level of lead in the blood. Even very small amounts can cause irreversible damage, though that damage might not be immediately clear. In the United States, the reference level of blood lead is the level at which public health actions are recommended to be initiated, and it is determined by the Centers for Disease Control and Prevention, based upon the understanding of complications caused by a given concentration of lead in the blood. Consistent with the research, the CDC lowered incrementally the reference level of lead from 60 back in the 1960s to 5. While the CDC sets a federal reference value, states can choose a level at which they decide to actually offer services. For example, prior to the summer of 2018, Illinois' reference level was set at 10 micrograms per deciliter. However, recent legislation has lowered the Illinois lead reference value to 5, so that at a level of 5, public health action triggers a nurse home visit and an environmental inspection. Let's now talk more specifically about the effects of lead poisoning and how lead affects the body. Generally, lead interferes with the interactions of divalent cations and sulfhydryl groups, and thus has widespread physiologic effects, as these interactions are involved in most biochemical reactions. For example, lead competes with calcium for entry into synaptosomes and interacts with various receptor-activated and voltage-gated cation channels. It can uncouple mitochondrial oxidative phosphorylation and disrupt signal transduction cascades. Ultimately, though, what it boils down to is that lead looks like a lot of other divalent cations that are naturally included in normal body functions. And when lead is incorrectly incorporated into these processes, it leads to cell death and irreversible damage. Thus, lead has effects throughout the body, but there are three main systems that are impacted, including heme biosynthesis, the renal system, and the central and peripheral nervous systems. What does this look like clinically? Well, as mentioned previously, at high levels, lead poisoning can cause outward symptoms, including loss of appetite, irritability, fatigue, abdominal pain, constipation, vomiting, hearing loss, and seizures. It can even lead to coma and death. However, most lead-exposed children never show these symptoms because most are exposed to lower levels of lead that leave them initially asymptomatic. Over time, children exposed to low levels of lead may develop deficits in overall intellectual ability, speech and language processing, visual spatial skills, attention and executive functioning, and social skills, as well as fine and gross motor skills. These deficits typically don't become apparent until a child is around school age and has to engage in a higher level of executive functioning. Often by then, it is too late to intervene. The deficits caused by lead were first documented in 1979 by Dr. Herbert Needleman, a pediatrician in Massachusetts. His groundbreaking study highlighted the correlation between lower-level childhood lead exposure and neurocognitive deficits. Between 1975 and 1978, Dr. Needleman measured the levels of dentin lead in the lost teeth of 270 6- and 7-year-old children and then evaluated their performance in the first and second grade. He found that those with increased levels of dentin lead were more likely to have lower intelligence scores, impaired speech and language processing, decreased attention, and worse classroom performance. When these children were re-examined in the 5th grade, children with increased dentin lead still had lower IQ scores than their peers, needed more special education services, and had higher rates of school failure. 11 years later, Dr. Needleman re-examined 132 of the children from the original study and found that those with higher levels of lead were 7 times more likely to be high school dropouts, 6 times more likely to have a diagnosed reading disability, and for those that stayed in high school, a lower class standing and a higher rate of absenteeism. Dr. Needleman's study was pioneering in that it substantiated claims that lower levels of childhood lead exposure could have wide-ranging effects on learning and behavior, and it proved that these effects persisted throughout childhood into adolescence and early adulthood. Later, in 2003, Dr. Richard Canfield, a researcher at Cornell University, looked specifically at the effects of lead at blood levels less than 10. Canfield took the lead levels of 172 children at 6, 12, 18 months, 2, 3, 4, and 5 years, and then administered a Stanford-Binet IQ test at the ages of 3 and 5. He found that an increase in blood lead concentration was inversely and significantly associated with IQ. Further proving the effects of lead on classroom achievement, a study released in 2015 by Ann Evans and colleagues looked retrospectively at blood lead concentration and third-grade Illinois Standard Achievement Test reading and math scores in over 58,000 Chicago-born children. The study found that for children with a blood lead level below 10, a 5 microgram increase in blood lead was associated with a 32% greater likelihood of failing third-grade reading and math exams. For example, according to her results, a child with a blood lead level of, say, 7 is 32% more likely to fail third-grade reading and math tests than a child with a blood lead level of 2. Studies have also shown over a 4 times increased risk of ADHD for children with blood lead levels greater than 2, with approximately 1 in 5 cases of ADHD in the United States being attributable to lead exposure, a statistic that is cited by the American Academy of Pediatrics Council on Environmental Health. We also know that children with elevated blood lead levels, even if low, have a significantly greater chance of engaging in delinquent or criminal behavior. One study found that a child between the ages of 8 and 15 years old with a blood lead level of greater than 1.5 has an 8 times greater chance of being diagnosed with a conduct disorder than a child in this age cohort with a blood lead level of less than 0.7. Another study found that every 5 microgram per deciliter increase in blood lead at the age of 6 increases a child's chances of being arrested for a violent crime as a young adult by around 50%. So all of that to say that there are significant effects of low-level childhood lead exposure that include but are not limited to decreased IQ, decreased cognitive performance, worse academic performance, impaired executive functioning, increased rates of reading disabilities and utilization of special education resources, increased incidence of ADHD and behavioral and mood disorders, and increased delinquency. It goes without saying that all of these things have significant effects on a child's future, including impaired academic performance, decreased employment, lower socioeconomic status, increased arrests, and ultimately decreased quality of life. This, in turn, also leads to profound costs to society. So what can you do? To start with, you should make sure that you are very familiar with the lead screening guidelines. Know that these vary state to state, so if you receive medical training or have recently practiced in a different state, the guidelines in Illinois may be very different from what you are used to. Also know that guidelines vary based on zip code and also depend on whether or not a child is insured through Medicaid. Be sure that you are testing according to the most up-to-date guidelines published by the State Department of Public Health. You should have a conversation about early intervention with any family who has a child who has been identified to have a lead level of greater than or equal to 5. Remember, as of July 2020, these children will be automatically eligible to receive services. Some families may not require the additional support that early intervention can offer, but many could benefit tremendously. Talk to your patient and see if early intervention is right for them. We can do better, and remember, it starts with you. Thank you for your interest and time.